Live from the Glasgow Electric Plant Board, Glasgow Wants to Know. With your host, Mr. Uhel Barrickman.
Welcome to another Glasgow Wants to Know. Tonight we have a subject which should be very beneficial to the community, and by community I'm talking about the city, Barron County and Metcalfe County, should be honored that these communities are being allowed to introduce a new protocol in how to immediately treat someone who is thinking he's having a heart attack or actually having a heart attack, and then treating him from that. To tell us about this, we have as our guest Dr. Walton-Shirley, a noted cardiologist here in Glasgow, and Mike Swift, the Barron County coroner and the director of the Barron Metcalfe County Ambulance Service. First, I will address you, Dr. Walton-Shirley, and ask you just what is this protocol?
Well, this protocol was born out of the frustration that a lot of patients don't even recognize the fact that they're having a heart attack at the time. And secondly, when they recognize they're having a heart attack, there are understandably some delays in receiving treatment. For instance, we wanted to find a way for patients to be able to get a diagnosis in the ambulance or at the scene, and then be able to implement the treatment directly in the ambulance setting. And the way that we've been able to accomplish this is to actually put equipment in the ambulance trucks that allow us to make the diagnosis of heart attack by transmitting the EKG directly from the ambulance to the emergency room physician. Then the emergency room physician actually reads the electrocardiogram, makes the diagnosis, and the paramedic then goes through a checklist to make sure there are no contraindications to receiving a drug known as clot buster. And then that clot buster can be actually administered in the ambulance on the way to the hospital. It will cut down substantially on the delay to receiving treatment, and we know that that's going to save lives in the long run.
How did you learn of the new protocol, and how's it sponsored?
Well, the protocol is actually something that's been tried in several places all over Europe, and then the Seattle, Washington group sponsored the MIGHTY study, which had about 1,000 patients in it. And there was a noticeable reduction in mortality in patients that could receive heart attack treatment in under 70 minutes from the onset of their symptoms. Their mortality dropped by about 8%. So Mr. Swift and I, knowing that we have some patients that are on the far reaches of our ambulance coverage, for instance in Metcalfe County and Fountain Run area, those areas, those patients, sometimes there's a 40-minute one-way trip just to pick up the patient. And in the heart world, we often say that time is muscle. So every minute that goes by when someone has a heart attack in progress, you're actually wasting heart muscle. And if you can cut down on that time, then you're going to save lives, limit complications of heart attack, and reduce the size of the heart attack. So we think that we're onto something here. It's been tried, it's been proven that it does work. But in order to implement this into an area like this, there are some difficulties that you have to overcome, such as the lay of the land, the topography of the land. You might not have good transmission of the EKG. We've had to go through all those hoops and make certain that we've gone to all these far reaches of both Barron and Metcalfe counties and make certain that we can transmit an interpretable electrocardiogram. And it has worked. So we're going to start doing this formally in the protocol in February of 1999.
Who is, other than the ambulance company and the hospital, the local hospital, is sponsoring this? In other words, I understand you have recently been to Dallas in regard to this program.
That's right. We went down to the American Heart Association meetings for other reasons as well, but we did attend a lectureship on the TIMI-19 trial. And TIMI stands for thrombolysis in acute myocardial infarction. And thrombolysis means just use of clot buster agent. There have been many TIMI trials. We're up to 19 now, such as which thrombolytic agent to use and the timing of it and the dosing of it. Now we're trying to get this into earlier treatment protocols into the ambulances, and the TIMI-19 investigators are doing this jointly with the Centacor Corporation, which actually owns Redivase, and that is the clot buster that's going to be used in the ambulance. The advantage of using the Redivase in this type situation is that it's a single bolus. It's just bolus into someone's IV instead of having to mix a drip and run it in like you do over about 90 minutes with some of the other clot buster agents.
And how did you learn of this, and what did you have to go through to become one of the, well, as I understand it, the only agency in Kentucky right now to update this protocol in Kentucky? Am I correct?
That's exactly right. We're the only site in the state of Kentucky that has been approved to deliver the clot buster agent in the trucks. Basically what we had to go through with was we had to start out in March of this year, and we had to seek approval of the Kentucky State Ambulance Board. We had to actually create a protocol. We had to tell them what equipment that we had available. We had to tell them that we have an ambulance director who's willing to make all the necessary changes to make this work. We had to go before the advisory board for the Kentucky State Ambulance Board. They gave us several things that we had to prove to them that we were capable of doing, like transmitting an interpretable EKG, and that we were willing to train our paramedics. We were willing to go through certain training courses, even for the emergency room physicians or any physicians that might be there that are going to interpret the EKG. Then we had to go before the Kentucky State Board of Medical Licensure, and the reason why we're approved as the first site is because I think that we have people such as Mike Swift and the paramedics, nurses, doctors that are willing to actually implement this and make sure that it works. Why can you not let everybody do it? Well, there are some emergency rooms in eastern Kentucky, for instance, that don't even have an emergency room physician there to interpret an EKG, even if it could be transmitted. There are some problems with transmissions of the EKG in the more mountainous regions of Kentucky. There are a lot of things that we have to implement, like paramedic training courses, so that when we finally get this in place and we're able to actually implement this, we'll be used as a template for the entire state of Kentucky. People will have to use it, look at us and see what programs we use to train not only the paramedics and EMTs, but also we have big plans to train the lay public as well. We plan a series of town meetings all over these two counties. We plan them tentatively to be at some of the grade school, elementary cafeterias. We thought those might be central sites. And we will teach patients when to call 911 and what the warning signs are of a heart attack. So not only do we not just want to get heart attacks treated earlier just by getting the medication in the vein earlier, we want to tell the lay public what it feels like to have a heart attack, what to look for, who's at risk, what are your risk factors. We hope to help both counties by doing some education on all levels.
Mike, can you do this now, or are you going to have to wait to a certain date?
I think that we're going to have to wait till we get the training and all this in place. We really actually, even before March, that the groundwork was begun from the standpoint of back a couple of years back, the hospital in cooperation with the ambulance service purchased some equipment that the LifePak 11 monitor defibrillators that go on the ambulance, and they purchased those. They purchased the cellular telephone interface. They purchased a receiving station to be utilized. The monitors were placed on the ambulances, and we've been using the monitors since then, so we've had some experience with using the monitors and getting some background information. Of course, the the use of the clot-busting medications is relatively new, and previously, before approval, was not approved for anybody in the state of Kentucky. So we've not had any experience with that. But Dr. Walton-Shirley and Dr. David Moss, who's the works at the emergency department, is also the ambulance services medical director, has put together a program to train the paramedics, and we're utilizing not just Dr. Walton-Shirley and Dr. Moss, but we're utilizing other professionals and healthcare providers in order to implement this training program for our people, not only the ambulance service personnel, but also the hospital personnel and other physicians that might have an interest and be concerned about upgrading the treatment of heart attack patients.
How many ambulances do you have?
Currently we have 6 ambulances, and of this number, 4 are equipped with the new type monitors, and they're equipped also with cellular telephone interfaces. And the date that we conducted the study, for the first study that we did an all countywide study, and that was on the April the 16th, 1998, which you remember was the date of the tornado that happened in our area. So I think that was an excellent experience from that standpoint, and we had very satisfactory results. As a matter of fact, we'd really received better results than what we'd even anticipated. We anticipated there would be some problem areas, and there were a few problem areas detected, but overall we had good coverage throughout the entire Barron and Metcalfe County areas.
Are you planning to equip the other 2?
We're going to be able to equip the other 2 ambulances with the cellular telephone, have the other equipment, so that we can interchange the monitors between those 2 trucks. But we currently staff 4 vehicles. 3 of those 4 vehicles are staffed 24 hours a day, 7 days a week, and a 4th vehicle is staffed from 7 a.m. to 7 p.m. 7 days a week. So we're only equipping the units that we are actually using and staffing on a daily basis. We have 2 units that are kind of our backup units, but they will be equipped with the technology as far as the cellular telephone interface. So it's just a matter of putting the monitor on board the truck, which all this is portable equipment to where it can be carried on and moved from, say, a patient to the vehicle.
You have 2 here in Barron County and 1 in Metcalfe, is that correct?
We have 3 trucks that are equipped in Barron County and 1 in Metcalfe.
What I mean, they're on those, in other words, you've got 3 that are on call 24 hours a day.
Correct. We have 2 in Barron and 1 in Metcalfe.
2 in Barron and 1 in Metcalfe
That's
County.
correct. And then 1 from 7 a.m. to 7 p.m. 7 days a week.
Who's going to train them?
Okay, I think, again, Dr. Walton-Shirley is going to be assisting, Dr. Moss is going to be assisting. We also have Dr. Jim Whiteside, Dr. Venkata Reddy, some of the staff from the hospital's continuing education program, some of the professionals from the skilled units, the coronary care unit of the hospital, the intensive care unit of the hospital also will be assisting in some of the training that will be going on.
All of this will be voluntary training?
Yes, well, as far as part of the training with the ambulance service. We're required to have continuing training all the time, and this would be part of that training.
But I'm talking about the people that give the training.
Oh.
Is that going to be voluntary training?
Yes.
On the part of the doctors
Oh,
and
yes,
so
definitely.
forth?
Absolutely.
Now, what type of funding are you receiving, if any, for this new protocol? And
Well,
from whence it comes,
okay.
if you're receiving any?
It's interesting that the Centacor Corporation, of course, is very willing, since they own the Redivase. They're willing to do what it takes to help us to do the public education. But oddly, and I think that it's a very good thing to hear that Genentech Corporation, that owns TPA, which is Redivase's competitor, is also willing to sponsor several of these meetings and to give us the monies necessary to do things like, you know, kitchen magnets to let people know to call 911 and the warning signs of a heart attack or whatever, and all the educational materials. It's really for the good of the community, and the Genentech Corporation, although they don't stand to benefit directly from this study, knows that our patients stand to benefit. So I think it's been very gracious of them to volunteer to help us as well. So Centacor and Genentech both will be sponsoring that. Plus the time spent by the physicians is going to be several hours. You know, we have to do the public education. Several town meetings are going to be required, and several hours of paramedic training. And I think it's good of the other physicians to volunteer their time and their information to help us to implement this study.
Explain for the public generally what you mean by block busting.
Okay, clot busting actually. When a patient has a heart attack, almost 100% of the time there's evidence of clot within the blood vessel. And we know now that blockages can consist of a combination of calcium and fat And what happens is that blockage is actually sort of like popcorn. It can rupture, the plaque can open and expose its inner parts, which are sticky, and that inner part grabs onto blood vessels, to blood cells as it flows through the blood vessel. So what happens is a patient may walk around with an asymptomatic 70-degree blockage. He may not or she may not know she has that, goes through all of types of activities, and then all of a sudden the plaque ruptures. And then you get a stickiness and a buildup of clot to the point that the flow of blood is blocked 100%. And about 15 minutes of time after that clot has totally blocked the passageway of blood flow to the heart muscle, the patient actually starts to have symptoms. Unfortunately, about 30% of people don't have symptoms with a heart attack. It's unbelievable that patients can sometimes walk into my office and say, I'm just here to get a checkup because mom and dad had a heart attack at my approximate age. And lo and behold, on our ultrasound, we see they've already had their first heart attack and they've never been hospitalized. What our hope is to help patients to receive clot buster who are symptomatic, who know that they're in trouble, help them to identify the signs of their heart attack, and then get this medication in the bloodstream. This medication is a pretty intelligent medication. It knows to go directly to the clot, and it actually acts something like Drano, and it cleans out or breaks up the clot. What it doesn't do is it does not do anything to the underlying blockage. You will still be stuck with your 70 to 95% blockage. But if you can just get a few percentage points of blood flow back to the muscle, you can restore the ability to wake that muscle up and keep it from receiving permanent damage.
How long have you had this new buster?
Renovase has been on the market probably 2 or 3 years now. It is a medication that we have been using for a long time in our emergency room setting. And this is an FDA-approved drug. You know, I want the lay public to understand, I want persons to know that we're not using an experimental drug. This is an FDA-approved drug that's used every day in our hospital. We used it today on a patient that was having a heart attack.
But you did have one before that took longer than this drug?
It took longer just to give it. We still think that the time to open up the blockage is still about the same. It's just a little easier to administer.
So that's the major difference between the two drugs.
When things are rolling in an ambulance and you're going in at 70 miles per hour or however fast we have to drive, it's just a little easier to be able to open up a kit, get the IV in, and bolus it. Just push it into the IV instead of having to mix the drug, hang it, and let it run for 90 minutes.
Now, when this new protocol is in effect, will the ambulance personnel be able to make the injection without first contacting the hospital, or will they have to first contact the emergency room doctor?
This is very much physician-directed. In other words, what will happen is that as the patient presents with symptoms, then of course this person is a eligible candidate at that point in time. They will then be given an EKG, and the EKG will be transmitted to the emergency department physician. At that point in time, then what will happen is the emergency department physician will then diagnose whether in fact the person is in fact having a heart attack, and from that information they will relay back to the ambulance that this person is in fact having a heart attack, and that then what they will do is the paramedic on the ambulance will then start an inclusion or exclusion questionnaire. Basically, the patient or patient's family will be informed of the fact that they're being asked to participate in this program. There are certain questions, past medical history. Do they have a history of bleeding ulcers? If that was the case, then they would be excluded from participation in the program because there's some other complications that could occur. And there's a variety of different complications. So there's a history taking that would have to be done, and at that point in time, if the person checked out and was an eligible candidate to receive the medication, that authorization would be granted by the physician to the paramedic to administer the drug. At that point in time, the drug would be administered to the patient, and shortly thereafter we hope then to be at the hospital. And if there's any other types of medications that need to be administered, any other types of tests and procedures that need to be done, that can be done in the emergency department. But all this is now being mobilized prior to the arrival of the patient. So whereas in the past the patient was brought to the emergency department and this diagnosis, this recognition, this mobilization all occurred after the patient got at the emergency department. Now this is going to be done prior to the patient's arrival at the emergency department. So as Dr. Walton-Shirley said, this is going to save time, and time is muscle for a patient who's suffering an acute myocardial infarction.
Can your paramedics read the EKG?
Yes, they would be able to read the EKGs and be able to ascertain from that information. But again, the drug itself is the whole program. Even as paramedics today, our program is physician directed, that we operate by state law under the license of a physician. So it's necessary that we go through the physician and we have physician input, and particularly in a program like this, it's crucial that we have physician involvement and working with the physician as a team, as part of the team, in order to benefit the patient.
Well, it's also good and necessary for the public to know that it's still directed by a physician, and that you do not have paramedics out there practicing medicine without the direction of a physician. Getting back to you, Doctor, we've been talking about symptoms of heart attack and so forth. What are the symptoms of a heart attack that the public should be aware of, and what should they do once they recognize a symptom?
Well, first of all, heart attack presentation, I've often said to patients, is sort of like women and their childbearing experience. It can be different, you know, in a lot of different ways for a lot of different folks. The classic signs of a heart attack and symptoms of heart attack are chest discomfort. I'm not talking about chest pain. You know, patients who describe a pain that lasts 2 seconds, that just is so severe that it knocks them to the ground, and then they get up and go, whoa, what was that? That's rarely ever heart attack related pain. The symptoms of a heart attack are much more subtle than that. As described to me by my patients that I've been treating for the past decade, they'll tell me that it was a squeezing sensation in the chest, or it was a pressure sensation, or just a feeling of uncomfortable awareness that something was wrong in the chest area. We also used to laugh and talk about Mylanta mouth. You can go down to the emergency room and see those patients that have been drinking Mylanta all day because they have a white ring around their mouth because they thought it was indigestion, you know. An indigestion type sensation is a common presentation. I've had a lot of patients that present also with arm discomfort, and they'll usually say, it felt like my arms were bursting, and they usually grab here between the elbow and the shoulder, or they'll sometimes say elbow pain. I've had a few people that presented with wrist discomfort, and it's a discomfort that doesn't go away for about 10 or 15 minutes, oftentimes associated by sweating, nausea, shortness of breath. I've had a few patients to present with a fainting episode that was a heart attack. And then there are some patients that just feel short of breath and under the weather and come to the emergency room just to see if they have the flu, and lo and behold, they're having a heart attack. Now, patients who are diabetic are notorious for having silent heart attack. In other words, they blame their symptoms on everything else, and the last thing some of them think of, unfortunately, is the fact that they could be having a heart attack. So any type of discomfort in the chest or arm area, I often tell patients anything from the belly button up to the earlobe that you can't explain away, that lasts for 15 minutes or so, 10 or 15 minutes, you might suspect that you could be having a heart attack. Back discomfort is another thing. Patients often blame their hiatal hernia symptoms on hiatal hernia when it really is heart attack. The other thing that needs to be said, I think, is that you shouldn't wait for signs and symptoms of a heart attack to get checked out. If you have risk factors for coronary disease, if you're a male over the age of 50 or a postmenopausal female, if you smoke at any age, you are at risk for heart attack. The youngest patient that I have treated is a patient from one of the surrounding counties who's 18 years of age, who is a smoker and had his first heart attack. I rarely see patients below the age of 45. I've never seen a patient below the age of 45 who had a heart attack and didn't smoke. I've never seen that. I know that it can happen, but that's very rare. Patients who have high blood pressure, who are diabetic or have high cholesterol, those are risk factors for having coronary artery blockage. And then family history. But in this area, by far and away, the most common thread that I see among young heart attack patients is they all smoke. Now, when you get to be over the age of 45, other things like diabetes and family history are important. And what counts as a family history? Well, if you have a mother or a father, a brother or a sister, those are the only relatives that count. Grandparents don't count, aunt and uncles don't count, but mama, daddy, brothers or sisters, if they've had their first heart attack between the ages of 50 to 60, then that counts as an early family history of heart disease. So you should get checked out if you have those risk factors.
Is there any way to differentiate pain caused by gas and the pains that you just described?
There really is not any good way to do that at home. I mean, some patients will take Tums and Mylanta and their heart symptoms will seemingly go away when in truth they would have gone away anyway, and it fools you into thinking, well, that was my hernia or my ulcer. The best way to do that is if you have risk factors, or if you have been hurting and you don't understand why, you ought to get yourself to the emergency room if you're in the middle of an episode, or get yourself into your family doctor and get an appointment for a stress evaluation. Stress evaluation, a stress test, stress ultrasound, or walking on a treadmill, or now we have available to us the non-stress stress test where you can lie down on a table and be given a medication that reproduces the same things that happen to a patient during exercise. Those things are pretty good to predict whether or not you're at risk for heart attack in the next year. So if you're someone that has a hiatal hernia and you have these other risk factors, what you need to do is what I do to my parents every year. My parents are in their late 60s. They have terrible family histories of heart disease. They both have risk factors. So I bring my mom and dad in every year and I throw them on the treadmill and I tell them to walk several minutes and let me make sure that there's not a sign that you're about to get in trouble with your heart. That's about the best way there is to figure out what's going on with your heart, besides the ultimate, which is doing a dye test. And doing a dye test is reserved for those patients that have flunked a treadmill test or are at high risk with some symptoms.
Now, suppose you have some of these feelings that aren't really painful but makes you suspicious. Should you call 911 in the ambulance or get in the car and go to the doctor?
That's a very good question. I think that if you are having symptoms that have been of more than, say, 5 to 10 minutes duration, and sometimes you know right off the bat, sometimes you don't have to wait that 5 minutes, sometimes your body's able to tell you something is really wrong, you better get some help. If you don't have immediate transportation to the hospital, I think that you should go ahead and call 911. Now that's a judgment that'll have to be made on the behalf of the patient and the family. I think that if you are out in the far reaches of the counties and you feel like you just cannot make it for an ambulance wait, I guess the best thing you could do, and Mike might want to comment on this, is to tell the ambulance, the 911 service person, I'm going to leave the house with my family member and my flashers on. This is the route I'm going to take. I want you to meet me, and we could stop and meet you on the road, pick you up, and put you in the ambulance, transmit the EKG, and treat you from there. Most of the time patients are better off to wait rather than starting out in a vehicle, but sometimes you have to use common sense and your better judgment, and sometimes it's better to get in the car and come ahead.
Especially if you're not in real severe pain, I could understand why you might get to the hospital quicker if you're out in the far edge of Metcalfe County or Barron County or the area that's served by the ambulance. You got any comments, Mike?
Well, I would agree with Dr. Walton-Shirley. I think it's a judgment call that has to be made. Of course, I think the big thing too is there competent people there to provide transportation. You know, if the family is real upset and someone's perhaps not capable of driving because of their anxiety and their emotions, certainly you don't want to put a person in a car that's having a heart attack and then scare them so badly as far as with driving that it contributes to the factor and cause additional problems, or perhaps even have the patient involved in an automobile accident and perhaps being injured. So I think it's a judgment call that people there, I think, again, reassuring the patient is very, very important. That the psychological first aid, if people kind of conduct themselves in a calm, cool, competent manner and act like they're knowledgeable as far as in the performance of their duties, then I think that adds a lot and helps reduce some of the anxiety and can help reduce some of the damage that can happen as a result of a heart attack, because there's not additional strain on the heart. I think that's very important. But I would agree that it's a it's a judgment call that a decision has to be made, and it is not uncommon for us to meet patients on their way to the hospital, and in those situations where time could be saved, perhaps that's the best thing to do under those circumstances. But again, we have to realize that if the person were to have an episode where they go into cardiac arrest, that CPR cannot be administered in the automobile, whereas it can be in the ambulance on the way to the hospital. So I think those are factors that you just have to look at, and it's really a judgment call.
I take it from what you've already said about a family member that they should accompany the patient. Should they go in the ambulance with the patient, or should they follow in a car?
Well, again, I think
I've heard discussions about that and even arguments.
I think again we have done this. We kind of work in a variety of situations. I think again, if the family member is going to be so upset that they're causing the patient additional anxiety, we would prefer that they follow the ambulance on the way to the hospital. If they are in a situation where they're in control of their emotions and can be a resource to the crew that's on the ambulance, the paramedics and the EMTs that are on the ambulance, and serve as a source of additional information, then I think that it's advantageous for them to accompany the patient. Normally, in those circumstances, they ride in the front of the ambulance and not actually in the patient compartment of the vehicle. So I think those factors, it's kind of on a situation by situation event that we have to look into it. Sometimes we encounter situations where people are experiencing chest pain, maybe because of some type of domestic problem that has arisen between family members. And if that's the case, you certainly don't want people who are feuding in the same vehicle where it's just a continuation of that type of situation. So I think it has to be based upon a judgment type call and the fact of the available information that family member can provide towards better caring for the patient that's in the back of the ambulance.
Well, now, most people that get upset aren't aware of how upset they are and whether or not they're going to cause problems, which raises the question, if you encounter that kind, do you tell them to follow and don't permit them to go with you? Do your personnel do that?
In some cases we do. I think that they have to make a judgment call based upon their contact with the patient, and we try and allow one person to accompany the patient in the ambulance if they can, under the situation, whether they're able to control their emotions and go from there. But we've had basically good success with that, and it's not been a real problem.
What happens if you have somebody that's living alone?
Well, occasionally that does happen, and in those situations, if the patient themselves are not able to provide information, then we're not going to be able to include them in the program, because there is certain information that we're going to have.
That's what I gathered
right.
from what both of you have already said, which makes perhaps a family member, if at all possible, very beneficial, because sometimes when the individual gets so upset, I imagine that they can't very well give you the information you need, or it may not be accurate.
Well, they may be in pain,
right,
etc.
Well, just to cite you an example of some of the things that happen, sometimes at the same token, family members can be a disadvantage. I recall one particular instance where we had a situation where we were called, and a gentleman, we were called for a apparent heart attack, and when we got there, the patient's family was there, and we started to ask the patient, where his pain was, and the family member immediately responded, he's hurting in his chest, and we asked the patient, how long have you been experiencing this pain? And the patient didn't get to answer. The family member answered, and really just about every question that was asked was answered by the family member, which led us to believe, well, we're hoping that this is the same information. This family member lived with this patient. So when we get to the hospital and finally in the emergency department, when the family member had to go to the admission desk and the patient was separated from the family member, that the patient was able to relate a completely different set of circumstances, and it was a completely different outcome than what was originally pictured by the family member. So I think, you have to make a determination based upon the family member's ability to provide information, and I think that paramedic and that EMT, they're very well trained in trying to make patient assessments, and the training that we're going to receive through this program is going to sharpen their assessment skills and questioning skills in order to ascertain and obtain the best possible information from a variety of sources, be it the patient themselves, be it a family member, be it perhaps bystanders that might be present at the time.
Pardon.
What happens if you have a family member that calls 911 and you get there and the alleged patient doesn't want to go?
I think the patient, as long as they are within their mental capacity as far as this, that they have the right to refuse treatment. Any person of sound mental judgment has the right. In dealing with this in several different situations, particularly through the district and the circuit court, I think that the issue has been that people have the right to make their own decision. The law says that they have the right to make that decision. The law doesn't say it has to be a good decision. The law doesn't say it has to be the best decision, but the law says that they have the right to make a decision. So based upon that information, if the patient refuses to go, then of course we would document that and not transport. We're going to encourage that patient. We're going to discuss that. We're going to encourage that. We may even get to the point where perhaps the patient says, well, I don't know, I want to go to the hospital. And we've even had some situations where the patient did not want to go by ambulance, but they were willing to let a friend or a family member take them to the hospital. Well, we've even followed the car to the hospital to make sure that there was no difficulties or problems en route while they were transporting, while the family member or the other person was transporting the patient to the hospital. So patients do have the right to refuse treatment. That's their given right.
What happens if you encounter a patient with Alzheimer's?
Well, again, as far as in that situation, there'd be a question as to whether or not that person has his or her mental facilities at that particular point in time. If there's been a guardianship appointed, then we could go with that. Again, if there's not been any court action or legal action taken, we're kind of in a situation where we have to do and make the best judgment that we can under the circumstances.
Are there counterindications to the use of clotbusters?
There definitely are. Fortunately, most patients are candidates for clotbusters, but if you were to tell me that you've had any history of brain bleeding, aneurysm, or brain surgery, you'd be excluded from receiving the clotbuster agent. Patients who have an active bleeding, if you've just been diagnosed with bleeding ulcers in the last year, patients that have been involved in motor vehicle accidents, patients who have even undergone, say for instance, colonoscopies that have just had a polyp removed in the last week, those patients cannot get clotbuster agent safely. And so they would be excluded from the study. They would still get an electrocardiogram transmitted to the ER doctor. There are other drugs that we can use, and if that patient meets certain time criteria, we would make every attempt to transport them for an acute angioplasty to get the artery opened up if they were not a candidate for clotbuster. Since we are geographically located as we are, we're in a rural area, it's tough to mobilize teams far away to try to get an angioplasty team in time to get the artery opened in a timely fashion. No matter where you're going to try to go, it's still tough. But we manage to do very well with that in patients who can't get clotbuster agent. So there are several different things. There's an entire checklist of what 20 to some things that we have to ask that patient. And if the paramedic checks yes to any of those questions, then the patient is excluded from the study, cannot get the clotbuster agent, and is transported to the emergency room. Now, after the physician actually sees the patient, talks to family members, we may be able to make a phone call or two to another hospital, perhaps where they had another procedure, or talk to their family physician to clarify something. That patient may then receive clotbuster agent, later on in the protocol.
I suppose you have a family physician and a cardiologist or an emergency room doctor that disagree as to whether it should be used or not. Who makes the call?
Usually the cardiologist is the one that has the final say, but I have to assure you that Dr. Whiteside, Dr. Venkata Reddy, and myself are certainly willing to listen to all issues and all sides. This is a very important decision. It is potentially a life-saving decision for each patient, and we have to weigh all of the evidence and then make a good decision. Fortunately, most of the time it works out okay. There is about a 4% incidence of complication with the use of clotbuster agents, and that includes life-threatening bleeding and life-threatening and debilitating bleeding causing stroke. Why are we willing to take a 4% risk? Well, a lot of patients will die without treatment, and your mortality without clotbuster agent is at least 30% from a heart attack. So that's why we're willing to take a much smaller risk by using clotbuster agent. And the heart attack, the size of the heart attack is limited. We have to shock people less, back to a normal rhythm. And the patients have a better quality of life who've been treated with clotbuster agent. You can imagine it, and I can because I started in the cardiology business right at the initial use of the clotbuster agent, and I have babysat many patients for days at a time in an intensive care unit setting. Used to put in a lot more pacemakers a decade ago than we do now because heart attacks destroy the ability of the heart to conduct electricity, and therefore we had to do a lot of emergency temporary pacemakers and those types of things. But you can imagine a gentleman or a lady that comes in with a heart attack that is going to destroy 50% of their heart muscle and left pretty much debilitated with shortness of breath, inability to lie flat at night and sleep, unable to return to work, unable to exercise and engage in those normal things that people enjoy every day. Or you can give clotbuster agent and significantly limit their heart attack size, restore blood flow, and provide a window of opportunity to get a heart catheterization done and bypass surgery or angioplasty performed so that that patient can lead a pretty normal lifestyle. Patients are going back to work sometimes at 4 weeks post-heart attack, whereas in the 1960s, early 60s, patients were put to bed for weeks on end, and a lot of them didn't survive because we didn't have this type of technology or medication available.
Suppose they've had a pen stroke or two.
Well, it all depends on the duration of time. Now, I think on our protocol, and I have to review this because we are not final on the set protocol yet. That's still under some scrutiny now. We will have our final protocol out in February of '99. But as it stands right now, if you've had any previous history of stroke, you cannot get the clotbuster agent in the back of the ambulance. Now, when you get to the emergency room setting, if someone is able to say, well, this stroke occurred in 1982, and it was from atrial fibrillation, which is a rhythm disturbance, and the patient has had treatment for that and had their rhythm stabilized and no more trouble, then that patient may still be deemed a candidate for clotbuster agent. There are two different types of pen strokes. One's a wet bleed type pen stroke where people have a stroke, and the other is a dry stroke, as we call it in sort of just slang terminology, and that is where a patient had a blockage from just a buildup of calcium and cholesterol in the vessel and blocked the flow. That's a very different stroke than someone who's actually had a rupture of a blood vessel that caused a bleed in the brain. That patient that's had a prior bleed in the brain will likely never be a candidate for thrombolytic therapy or clotbuster agent.
Can you tell by CAT scan or an MRI which type they've had?
You can a lot of the time, but if it's a very old situation, sometimes that can be difficult. And it can be sorted out with MRI scanning, etc., and the help of a neurologist too as well. We're really fortunate to have some excellent radiologists here in this area that command the use of an MRI scanner and CT scanner quite handily, and they can help us sort those things out in the emergency room setting. And for that reason, you see why we would have to declare that patient a non-candidate for clotbuster till we got them to the hospital, because we may have to look back on their medical records, or we may have to have more workup performed before we can do that. I might also add that this risk of intracranial bleeding or bleeding in the brain is accentuated by having a really elevated blood pressure. And one of the basic rudiments to giving clotbuster in any setting, hospital, ambulance setting, no matter where, is to do a blood pressure. And if your blood pressure is a certain elevation, then we cannot deliver that safely until it's brought down. Now, fortunately, treatment of pain with morphine and giving of nitroglycerin and other medications will usually help stabilize that blood pressure so the patient can become a candidate in a matter of minutes.
Oh, she had some reference there. I made a reference to shock treatment. I take it you can do that on your ambulances.
Yes, sir. That is a part of our protocol. It's been a part of our protocol for years. And in addition to not only the ambulances, every fire station in Barron and Metcalfe County is equipped with an automatic external defibrillator, and the volunteer firefighters are trained in the use of an automatic external defibrillator. Anytime that we receive a call for an emergency situation in Barron and Metcalfe County, in addition to the ambulance being dispatched, the nearest volunteer fire department whose jurisdiction that call originates is also dispatched to the scene. The fire departments have the automatic external defibrillator. So in other words, in many cases where the underlying rhythm is in fact an abnormal rhythm caused by the heart being in ventricular fibrillation, or where the heart is actually quivering rather than effectively pumping blood, that the treatment of choice is defibrillation or the electrical shock. The sooner that that shock can be administered to that patient under those circumstances, the more likely that the heart is able to convert back to a normal rhythm. We've not corrected the underlying problem, but we've bought time to get drug therapy and other types of medications, get the patient to the hospital for additional definitive treatment and other types of procedures that could be done. So not only are the ambulances equipped with that capability, but also the volunteer fire departments, the city fire department, the city of Glasgow, both stations there are equipped with that particular type of equipment. And basically it's from a sense of standpoint not only of community service, but even with the firefighters. Probably the underlying cause for many episodes of ventricular fibrillation is carbon monoxide poisoning, which as firefighters fighting fires, they are experiencing that. So it's kind of a self-preservation community service type of program that they are being able to provide to the citizens of Barron and Metcalfe County. And we're very fortunate, and that was one of the factors that enabled us to participate in this type of study, because we're one of the few communities in the Commonwealth of Kentucky and few communities in the nation that have the capability to deliver that type of care to patients on each and every call.
Could I interject something too as well here, sir? Dr. Whiteside, I think, put this best, and I heard him say this at a conference once. You know, you've heard everybody talk about patients who died of a massive heart attack. You know, in truth, most patients don't die of a massive heart attack or just a large area of heart muscle damage. They die of an electrical phenomenon called ventricular fibrillation. I mean, if that patient just had access to the appropriate amount of electricity with a shock, most people could be saved. It is the delay between the onset of your heart beating abnormally in ventricular fibrillation and actually getting the shock delivered that causes the mortality to rise minute by minute. That's why I think we're so fortunate we have people like Mike who've made certain that we have as many of these shocking devices as we can spread around to all areas of these two counties. What part of this protocol is going to include is teaching patients where they are and where these defibrillators are and how to use the defibrillators. I think those are really, really important issues, and we're going to combine that with things like treating about heart attack recognition and how to call 911 and the availability of clotbuster, along with being able to know how to shock your neighbor or shock your family member. This defibrillator is absolutely the easiest thing you've ever seen. It's very intimidating to think about that, but you actually have instruction there that says put the paddles on here, push this button. The machine reads whether or not you are in or out of rhythm and tells you hit this button now for shock. And that can make the difference between life and death.
I think we've just done a service because I don't believe the public generally knows that the fire departments have them.
I think that we've been very fortunate, and the fire departments have been very cooperative in working with the ambulance service, working with the hospital. Dr. Walton-Shirley has reviewed several of the cases that they have been used in the past, and Dr. Moss reviews those. There's a written record of the procedures. The machine has a recording tape that records the information that is stored or gleaned from the patient contact, and so they're reviewed and kind of critiqued as far as it is to make sure that the proper procedures were utilized. But again, the machine, basically I think the hardest part of the machine is turning the machine on. Once the machine is turned on, it pretty well takes care of itself, and it gives you instructions as far as what to do.
How long have the fire departments had them here?
It's been about a year and a half, maybe between a year and a half to 2 years. And again, Dr. Walton-Shirley and Dr. Whiteside and Dr. Venkata and Dr. David Moss were instrumental in that. They kind of spearheaded the program and advocated the use of that, and the Barron County Physical Court helped to purchase the devices for the various volunteer fire departments. The Glasgow City Council approved the purchase by the Glasgow Fire Department. In Metcalfe County, the volunteer fire departments on their own initiative purchased the equipment, and it was a pretty sizable expense. So they were about around $5,000 a piece for each piece of equipment. So it was a very sizable expense, and particularly in Metcalfe County, where a lot of pancake fries and fish fries and cake sales and things like that went towards the acquisition of these pieces of equipment. But again, they're very beneficial and do save lives.
It's important to also note that, Gary Hogan, his enthusiasm for treating patients rapidly in the emergency room also fuels this kind of interest too as well. And David Moss is board certified in emergency medicine and pediatrics too. We're fortunate to have him heading up our ambulance service as the medical director. Where if not for all these things that had to fall in place, we couldn't have gotten this program implemented at all. So I'm grateful to be working with folks like that.
I think that is very important. I think it's a variety of people. I don't think any one person or any one individual has made this program work. It's been a joint cooperative venture, and the hospital has been very cooperative and very assisting in whatever they could be done. The various units of government have, the ambulance service, the EMTs and paramedics, bless their hearts, that they are involved with this each and every day, and they're the folks that are going to be, the front line, the volunteer firefighters, the job. They just do a tremendous job. All these people all together, working together, the community itself. This is just a great community to live and work in.
Well, we're fortunate to have this protocol in the beginning of it. I don't think there's any doubt about that. How much training does your paramedics and EMTs get?
Okay, well, first of all, to be initially certified as an emergency medical technician or an EMT, there's about a 15-week program that it's about 120 hours, the initial training, and basically they're allowed or trained to provide basic life support, which is basically to administer CPR, to assess patients, and to provide stabilization care to the patient en route to the hospital. After that type of training, they're eligible to take the paramedic training, which is about 1,500 hours in length. It's about a 2-year program, and through that program, they build upon the basic life support. They build upon CPR and things like this by providing advanced airway care, the administration of drugs, the interpretation of abnormal heart rhythms. And so once they're certified and they go through that program, then once you're certified, then every 2 years you have to be recertified. The EMTs go through 24 hours of continuing education. The paramedics go through 60 hours of continuing education over a 2-year period of time. In addition, the paramedics are required to have specific classes such as advanced cardiac life support. They are evaluated by Dr. David Moss on an annual basis, and a report is given. And then if we do all this, then we're allowed to take a written exam, and we have to score 80% or better on the written exam. So it's a continual process of education and training, and the program that Dr. Walton-Shirley and Dr. David Moss and the other physicians within the community are putting together will help to fill this time block that we have in order to have our continuing education and work towards that continuing education.
Where do they normally get their initial training?
Their initial training, in the past, they've had to go to Bowling Green and other places, Elizabethtown and Louisville. We just recently finished up with a paramedic program that was conducted here at the T.J. Sampson Community Hospital. It was the first paramedic program ever conducted in Glasgow, Kentucky, and we graduated 12 paramedics, which we started with 20 people. Well, we actually started with 25 people, and we finished with 14, and of those 14, 12 were successful in being certified as paramedics. So we started with 25. We have, state law requires us to have 20 people in the class. We originally started with 20 people in the class and had 5 alternates. Within the first 2 weeks of the program, 5 people had dropped out of the program, and so the alternates were able to come in, and we even lost some of those over a period of time. But it's a very extensive training program. It's a very time-consuming program, and the certification process is a very intimidating program. Kentucky is the only state in the nation where the paramedic student is exposed to a oral examination, where the paramedic student is one-on-one with a physician who then questions them about scenarios in emergency care. And it's a pass or fail type situation. So it's a very extensive and very profound program.
I know that recently the hospital has become a part of the governing body of the ambulance service. Perhaps you should explain to the public generally the governing body of the service.
The ambulance service is governed by a board of directors, and prior to the hospital coming on board as being a member of the governing body, the entities involved were the City of Glasgow, the Barron County, Metcalfe County, the City of Edmonton, and originally the City of Cave City. After about a year, the City of Cave City dropped out, and the other 4 entities involved, the City of Edmonton, Metcalfe County, Barron County, and the City of Glasgow, and they funded the operational deficit of the ambulance service based upon population, their portion of the total population of Barron and Metcalfe counties. And prior to that period of time, Barron County paid approximately 50%, the City of Glasgow paid approximately 30%, Metcalfe County, as far as the city and the county, have paid about 30% also. In January of this year, the hospital came on board, and rather than paying on percentages as had been done in the past, is based upon number of seats on the board. So the City of Glasgow has 3 seats on the board. They pay 10% per seat, which is 30%. Barron County has 3 members on the board. They pay 30%. The Metcalfe County, the City of Edmonton, and Metcalfe County has 2 seats, a total of 2 seats. They pay 20%. And the T.J. Sampson Community Hospital pays 20% and has 2 members also. So that makes up the joint membership of the board, and that accounts to 100%.
We've got about 2 minutes. You got any final message you'd like to tell the public, Dr. Walton-Shirley?
I'd like to encourage them, as many as can, to attend these town meetings that we have that are coming up over the next couple of months. And the reason being, we're going to help you to recognize the warning signs of a heart attack. We're going to help you to identify whether or not you are at risk for heart attack. We're going to tell you more about the ability to receive the clot buster in the back of the ambulance and cut down on your heart attack size to obtain earlier treatment. And I'd appreciate it if you could tell all of your friends and family that we're going to have this available in the coming months. We are targeted to start in February of 1999. You can still get timely treatment of your heart attack until that time by calling 911. We will still transmit the EKG, but we actually cannot implement the protocol until February of 99, and we're hoping that we'll help the entire state of Kentucky, especially the rural portions, to obtain earlier treatment of heart attack. We hope to be able to help everybody.
But even now, you can transmit the EKG,
Yes,
which
sir.
is taken on the way.
Yes, sir. We sure can.
And each of the ambulances that's on duty, the 3 ambulances on duty, is capable of doing an EKG.
That's correct, sir. We have a total, each ambulance is equipped with an EKG monitor, and of those, as far as that 4 of the 6 are equipped and capable of transmitting by cellular telephone to the hospital.
And it's working very well.
Yes, sir.
How long have you had that?
About a year and a half.
I think you should do a better job keeping the community updated in what's going on in your ambulance service. And
We're trying.
I noticed the hospital is doing television commercials these days.
That's correct.
I think that helps too.
Yes, sir.
Sure. We're in a high-risk area. It's the tobacco belt, a lot of family history, gene pooling. We have a lot of patients that are at risk for heart attack, and we want to be able to get there before the heart attack does.
I thank both of you, and I think each of you is doing a great service for the communities. Thank you very much.
Thank you.
Thank you.